So my name is Kashaf Zaidi. I'm a PGY3 at AdventHealth Orlando in the internal medicine department. And this was a project that I worked on with a few of my colleagues, along with my mentor, Dr. Maharam. So the idea for the project came from, I had a few patients who had like resistant hypertension and even hypertension requiring 2, 3 medications. So we were basically looking into how sleep apnea kind of makes everything worse and exacerbates it. So that made me do some literature review, and 50 to 60% of the patients with OSA had daytime hypertension, and a large percentage also had nighttime hypertension. So a prior quality improvement study that I reviewed showed that only 1% of the population in their clinic was being screened for sleep apnea. Now, a lot of literature review was based off of USPSTF recommendations, ACP recommendations, and basically most of them have shown that in the low risk population and in general screening, it's really not appropriate and not recommended. However, there is a high-risk group that we focused on, and that included patients who had hypertension and who had a BMI greater than 35 and who had aged more than 50 years. Now, unfortunately, we don't have a very reliable with a high sensitivity screening tool or validated questionnaire. We do have validated questionnaires, but their sensitivities are not that high to screen for sleep apnea. But the most commonly and easily used one is usually stop bang. So that's these are elements from that too. And these are basically what we use to characterize the high-risk population. So we use EPIC, so that has a slicer dicer component that we use to extract patients who met all of this criteria. So the 3: hypertension, BMI, and age. Then 110 charts were selected for detailed review. And the review, we basically saw how many of them had been referred for sleep studies in the past, how many of them how many medications they were requiring for their hypertension, if we had even discussed sleep apnea with them in the clinic, and how well controlled their blood pressure was, basically. So these are the things that we found out. And then after that, we noticed that only about 39% of the population was, in fact, sent or referred to sleep specialists. And unfortunately, even out of those, we were only a part of the screening for 9% or so. So 9% of them, we had a stop bang questionnaire that was administered, and, they were screened and then referred. A lot of these referrals were being made by specialists, including cardiologists, pulmonologists, that they were seeing outside of the practice as well. So the idea came in from there. And so we basically made a fishbone analysis. So we're trying to understand what goes wrong in this entire process, or what can be improved, basically. So there are people factors, there's level of training, it's a residency program. So, their knowledge gap for the residents themselves, their year of training also had an impact. Whether, who they're being chiefed by and what their expertise are in that matter are also relevant. And then we had some biases, like it doesn't help, it doesn't help anybody. Like, I know it doesn't help generalized screening, but it does help the high-risk population. So that was a bias that, we were able to come around. Another thing was, because we're a residency program, and I think a lot of other PCB clinics also go through this, even if they're not residency affiliated, that we're all short on time. So we have patients scheduled with like 15, 20-minute, 30-minute visits, and, we're like essentially spiraling. So at that point, another thing that we noticed was there's no reminder. So it's not a part of our inherent template. There are no physical tools to assess it. So you're basically relying on people having the screening tool on their phone, or, accessing an app or a website, and it kind of takes time. So nobody really goes through that entire process. So some equipment things, which basically included the no lack of physical tool in the clinic. Then we also saw that there was variation based on the time of the day. So what time they're actually seeing the patient, which patient is it in their entire day of patients. So if it's the 15th patient, or the first patient, so it kind of varies, and we've all been there, so we know what we're talking about. And then policies. So we didn't have like a generalized screening policy for sleep apnea for the population, because like I said before, it hasn't been proven to be helpful, but it does help the obesity population and the population impacted by, high age and all of that. So all in all, the intervention that we introduced was to serve as a constant reminder. We basically incorporated these 3 risk factors within our template. So now what it appears as is does this patient have age more than 50, BMI more than 35, and hypertension? Then it's like, yes, consider further screening. No, you don't have to do anything. Move on with your encounter. Now, the other thing that USPSTF and ACP and other literature has also supported is the presence of symptoms. So if they have these risk factors and they don't have any daytime symptoms or any sleepiness or tiredness or anything, at that point, it's not considered very appropriate to even be able, to go with further screening. However, if they're symptomatic, then, if you give them a CPAP, it's shown to reduce their systolic blood pressure by about 7 to 10 millimeters of mercury. And that, you and I all know, it can be significant when we're talking about 4 medications or 3 medications for blood pressure. So other than that, the other thing that we also obviously want to focus on is the complication rate. So some of our patients, 15.5% had pulmonary hypertension, 14.5% had AFib, and 22.7% had a prior history of myocardial infarction and stroke. And sleep apnea itself can be an independent risk factor for all of these conditions. So the project's goal is basically to optimize this and enhance the screening practices. So our goal is 50 to 60%. So currently, even if we're anticipating that we're talking to about 35% of the population at this time, so the goal is to double that. And how we're monitoring so it's an ongoing project, and how we're monitoring this is, on like a 2-weekly basis, we're reviewing charts to make sure that our numbers are good, that our percentage of screening is going up, and that people have it incorporated in the template. So it's kind of a reminder. So even if they omit it, it's something that will be reportable. So that's where we are right now, and that's all I have to say.